also discuss some of the other pillars that are needed to be implemented in terms of achieving remission for patients with type 2 diabetes. I have nothing to disclose, and I only have very few but very important objectives. First, we will define diabetes type 2 remission, and then let's discuss on lifestyle medicine dosing. And then we will present a case of diabetes remission using intensive therapeutic lifestyle change, or we call this ITLC. Traditionally, we know that diabetes is a chronic condition, and in our clinical practice, we understand and we provide a bit of education to our patients that this is a progressive disease with a potentially serious sequelae. And we thought that this is a lifelong disease, and that this is what we keep telling our patients, that once you had diabetes, you will always have diabetes. And we also know that treatment for type 2 diabetes often begins with oral medications, and then eventually we would require patients to add more treatment, like we go for monotherapy, and then eventually dual therapy, and then triple therapy, and then sometimes we end up requiring our patients to go for insulin therapy. And as the disease progresses, drug therapies are often intensified, and then here we can see that we rarely reduce to control glycemia. Now, but in the 21st century approach of diabetes type 2, the goal here is beating type 2 diabetes into remission. And so whenever we see patients with diabetes in our clinic, our goal is not only to manage their diabetes, but our goal here is for them to achieve remission on their diabetes and hopefully reversal of their diabetes. So I will be presenting here a case of NS. He is a 73-year-old male, married, from San Joaquin, Iloilo. He's a retired government official. He came into our center with a complaint of uncontrolled blood sugar of about 375 milligrams per DL, despite taking 2 maintenance medications for his condition. The patient is also hypertensive, hyperlipidemic, hyperuricemic with gouty arthritis, and also with fatty liver disease. So he has maintenance medications for all these conditions too. Now, looking at the lifestyle vital sign of the patient, he eats 3 servings of meat or fish in a day, mostly fried or sauteed. He also eats 1 to 2 servings of vegetables, mostly sauteed with oil on a daily basis. He also drinks 1 to 2 servings of sugary beverage daily, and he eats 1 to 3 servings of bread or other processed foods daily as snack. And he would rarely exercise. He said it could be 1 or twice in a month. And he sleeps well, as claimed, of about 6 to 7 hours at night, except during gouty attacks. Now, the perceived stress score is 8, which is indicative of having low stress. The patient is a non-smoker, and he drinks alcoholic beverages occasionally, about 1 to 2 times in a month. Now, the patient's weight is 200 pounds. Height is 5'9", so that is an equivalent to having a BMI of 29.5. His blood pressure is 140/80. Heart rate is normal. And the initial laboratory result revealed an FBS of 375 milligrams per DL, an HbA1c of 9.6%, LDL of 289, HDL of 32. Triglyceride is also elevated at 276. SGPT and SGOT are also elevated, and the serum uric acid was also elevated. So what we did for the patient, I recommended him to enroll to a lifestyle medicine resource program. So this is in fact an online program for patients who cannot visit us quite often because of the distance from our center. And a nutrition assessment and counseling was given to the patient. Of course, exercise assessment and counseling, pain management, and of course we co-manage with his endocrinologist. We would want to refer the patient to a nutrition and dietitian, but we are unable to do so because we are not able to find someone practicing near his place. And with the nutrition management, we started on transitioning to a plant-based diet. So in this kind of patient, he's already a 73-year-old patient, and he said that he can add vegetables to his diet, but he cannot really promise that he can remove all the things that he's eating. And so in lifestyle medicine, we are always taking note of what's workable and what's doable for the patient. We always meet them from where they are. And so we always talk about transitioning instead of telling the patient, do not eat this or do not do that, especially during first visit. And so we started adding 3 servings of vegetables, preferably no oil, on a daily basis for the first 7 days in our program. And then we started introducing the jump start to the patient. So we thought that he's already ready. His taste buds was used to consuming more of a vegetables compared to the usual meat that he's consuming. And so we already introduced pure whole food plant-based diet for the patient in the next 7 days in our program. And so we also introduced conversion of processed food to whole food choices. So like, for example, we introduced conversion of his white rice to brown rice, and conversion of his favorite biscuits and crackers to tubers. And in this kind of patient, we emphasize on food types rather than calorie counting. We did not included calorie counting in this type of patient because he is unable to understand the language in terms of calorie counting. And so you could imagine a patient having difficulty in understanding whenever you talk about certain percentage of calorie that he will be taking whenever he eats a certain plate filled with food, right? And so it is always easier for us to talk about food types rather than technically calorie counting. Other recommendations included physical activity. So we initially started off with increasing non-exercise physical activity thermogenesis, or we call this the NEAT. Remember, this patient is already 73 years old and he used to be really sedentary. And so we cannot just let him do exercise. And, remember that he's also suffering from gouty attacks. And so we initially started with improving his movement every single day. And then we eventually introduced moderate physical activity, about 30 minutes, 3 days in a week. And we also advised the patient to decrease watching television, YouTube, or Facebook because it was his pastime. It used to be his entertainment for every single day. As much as possible, we want him to reduce or decrease his watching hours while sitting. But we also encourage him that if you really want to watch or you really need to watch, maybe you can do walking somehow. And then, of course, we also manage patients' pain. So it's really important, to look into this. And so we provided medications and, of course, anti-inflammatory foods, to improve the patient's gouty attacks. And so after 3 weeks in the program, we repeated laboratory tests, and the FBS of the patient went down to 180, LDL went down to 150, HDL went up to 44, triglyceride also went down, or SGPT and SGPT were already at the normal range, and the serum uric acid as well. Now, it is also notable that the patient's BMI went down to 28.2 as well. Now, at the end of the program, we repeated lab test again, and our FBS is already 115.82. We're so happy that it went down to this non-diabetic level already. HbA1c is 7%. The LDL went down to 132, HDL still at 44, triglyceride even went down to 120, SGPT and SGOT also went down, and our uric acid is at 5.3 milligrams per DL, and our BMI went down to 26.8. And so after the patient graduated from the program, we required him to come back 4 months after for follow-up. And as you can see in his follow-up laboratory test, FBS is has normalized already, and it's about 100.20, but still at pre-diabetes level. The HbA1c went down to 5.5%, a non-diabetic level already. LDL was 94, HDL was 42, triglyceride was normal, HGPT and uric acid was also normal. The BMI also went down to 25.6. And so we decided to ask the patient to come back after 6 months. So here, as you can see during follow-up, the FBS is already at the normal range. HbA1c is also at the normal range. LDL, HDL, triglyceride, the SGPT, the SGOT, uric acid, and the BMI were also at the normal range. Now, in this case, you will really clearly see a remission in the case of this patient, as we are not already using any diabetes medication since January of 2021. And so now we will be discussing on the next objective for this presentation. Today in the Philippines, 1 in every 5 Filipinos are either pre-diabetic or diabetic, with the highest rates among older, overweight, and individuals with hypertension. Now, looking at this, we see that the current disease management approach for type 2 diabetes is primarily aimed at delaying progression of the disease rather than remission, right? Now, whether we like it or not, when we talk with our colleagues, and even when we listen to lectures about diabetes and education that our physicians are providing the patients, whenever the patient would ask about possibility of reversal of diabetes, the next thing that we would hear commonly is that diabetes is non-curable, right? But tonight, I'd like to dissect very quickly the definition of diabetes remission and the possibility of reversal. In lifestyle medicine, we always say that diabetes is the mother of many types of chronic diseases. And we are seeing younger population with these conditions. Now, as we look at the current evidences that are coming out, a shift toward treatment that can not only prevent but also reverse type 2 diabetes and produce complete remission is the single greatest need in type 2 diabetes care. Now, the field of lifestyle medicine is poised to make this contribution. Now, several definitions of type 2 diabetes remission have already been circulated. The American College of Lifestyle Medicine uses the definition published by Buse et al. In 2009, which requires blood glucose level on par with the healthy individuals without diabetes. Now, remission here was defined by achieving glycemia below the diabetic range in the absence of pharmacologic therapy of at least 1 year duration. Now, they also defined partial remission, which is a subdiabetic hyperglycemia with HbA1c of less than 6.5% and the fasting glucose of 100 to 125 milligrams per DL. And they also defined complete remission, which is a return to normal measures of glucose metabolism with HbA1c in a normal range and a fasting glucose of less than 100 milligrams per DL. But here we have another leading definition of remission, which comes from the Association of British Clinical Diabetologists and the Primary Care Diabetes Society, who proposes similar but a lot simpler and less stringent definition that requires blood glucose level to fall below the diagnostic criteria of diabetes for a period of only 6 months. Now, here we can see that a growing number of clinical experts are already discussing the concept of remission as the treatment goal, inspired by the outcomes observed following weight loss, fasting or fasting mimicking diet, bariatric surgery, and most recently, intensive lifestyle modification. Now, given the current upward trend in diabetes incidence and recognizing the need for intensive therapeutic lifestyle is essential to advance the solution to treat the causes of disease and contain the spiraling cost of diabetes management. Now, we also know that the underlying cause of diabetes type 2 have long been identified as excess weight and insulin resistance. But there has been a lack of consensus on whether insulin resistance may be the cause of excess weight or whether excess weight is caused by insulin resistance. But it has been suggested that there has been bi-directional relationship. However, one thing these two causes have in common is that they most often result from excessive caloric intake that causes rapid insulin resistance due to the increased oxidative stress in as little as 1 to 2 days. Now, this occurs before weight has been gained. And we know that ongoing intake of excess and poorly chosen calories maintain the insulin resistance. We also know that human physiology actually preserves and conserves calories even when consumed to excess, and this is illustrated by morbid obesity. While adipose tissues store much of the excess calories, as the excess accumulates, it is stored in other tissues, notably in the liver and pancreas and also the muscles, right? Now, in these non-adipose tissues, caloric excess leads to lipotoxicity, and we all know that. Meaning the excess fat, which are called the intracellular lipids, are stored in these cells and inhibits their proper functioning. They disrupt normal glucose and insulin metabolism. Now, going to the myocellular lipotoxicity, we know that it inhibits glucose uptake, right, by affecting the glucose transporter. Now, this produces peripheral insulin resistance, which require greater amount of insulin to push glucose into the muscle tissues. And this resistance is reduced with exercise as muscle tissue consume energy and they become more responsive to insulin. Now, if you look at pancreatic toxicity or lipotoxicity on the other hand, this inhibits beta cell insulin production and reducing the amount of insulin that should be available, supposed to be, to overcome the insulin resistance in muscle and other energy consuming tissues. I would want to discuss more on the pathophysiology of diabetes type 2 remission and reversal, its development, so on and so forth. But anyway, you'll be learning this, as you go along with your course in prediabetes and diabetes reversal. For those who are already enrolled on that course, so I'm sure that you have been starting to work on your modules. But let me go straight to lifestyle medicine intervention. I wanted to emphasize here that the importance of appropriate dosing in the context of lifestyle modification can be hardly overstated. Dosing is a prime therapeutic importance in a pharmaceutical context, and in lifestyle medicine, it is no different. Okay, now the same dosing principle applies to lifestyle medicine. So that means the lifestyle modification required to produce type 2 diabetes remission are significantly more intensive than those sufficient to prevent type 2 diabetes only. Now, clinicians whose patients achieve remission do so by using sufficiently dosed lifestyle changes such as diet, exercise, and other behavioral intervention, as you can see here in this published paper. Now, remission is not reported, take note, in inadequately dosed lifestyle changes such as, for example, eating more salad or simply reducing meat consumption in each meal. Research show now that remission is achievable for majority of short duration of less than about 8 years type 2 diabetes patients, and many with longer duration with sufficiently intense lifestyle medicine interventions. But we also have to take note that we also have failures in the lifestyle programs that we offer patients, right? But most failures are due to inadequate dosing of lifestyle medicine and not to any inherent deficiency of lifestyle medicine as treatment. Now, patients find lifestyle medicine treatment acceptable and desirable when treatment produces remission, and this you can see in this study. Now, a personal demonstration of remission can reset the lifestyle goals patients set for themselves. Now, at the time, the degree of dosing is influenced by the patient's willingness to change and the inherent challenges in making adequate changes without adequate support and guidance. Now, here in this paper, you will see that adherence to conventional diet and lifestyle guidelines for diabetes management has been identified as problematic for type 2 diabetes patients specifically. Now, identified key barriers include the lack of communication and the support from healthcare providers, as well as inadequate education provided to them. Basically, we only see patients for like 10 minutes, maybe 20 minutes, and of course, education may not be sufficient, with that very limited time. And here, this is where lifestyle medicine specialists provide the education, the support, and modeling necessary to successfully and realistically achieve a sufficiently strong intervention dose, and of course, to accomplish the goal of remission. Now, research show that sufficiently dosing of lifestyle interventions will induce remission in half or more of subjects with type 2 diabetes. Studies also revealed that not all lifestyle intervention produce remission, and that remission rates are lower for longer duration type 2 diabetes, and we also have to take note of that. So this is not one size fits all, okay? It doesn't really mean that you provide lifestyle intervention to patients with diabetes. We are sure that they can get well, okay? We are sure that we can reverse their condition. And adherence and individual factors may also affect the remission rates. All right. Now, the highest remission rates, looking at the studies, are also seen and noted similar to those with bariatric surgery. Here, I want to share with you this slide. You see, prior to 1997, the diagnostic criteria for diabetes was a fasting blood glucose of 140. But it was also in 1997 that a large consensus came together and changed the diagnostic criteria of diabetes from 140 to 126 fasting blood glucose, right? Now, the reason being is because of the exponential increased risk of complications that begin to curve up powerfully, noted at around 126. Now, and this number catches the cases early as well. Now, it was also in 1997 that Dr. West and his colleagues actually created this 5 stages of blood sugar increase. Now, this chart emphasizes that diabetes is not the beginning of the high blood sugar, and many other biological processes happened prior to that. Okay, now it provides education to patients of where they were in every stage relative to their diabetes. And this is a very good educational reference that was published by the Department of Health and Social Services of Guam with a grant coming from the Center for Disease Control. And we also take note that in 1997, that the new criteria to define prediabetes was also published. I personally use this chart because I could see that patients would use this as reference as to where they are in their journey in remission, of their condition, whether they are progressing or whether there is regression of their condition. Here you will see that in 2009, the American Diabetes Association finally came out with a definitive guideline on how to define cure of diabetes. In fact, this is a very, very well done paper. And they have this very nice statement, I should say, with a mission. Their mission is to prevent and cure diabetes and improve lives of all people who are affected by diabetes. Lifestyle medicine specialists could not agree more with the American Diabetes Association statement. Now, the key issue now here is we have to live with that mission and translate this to patients' care. Patients should know and understand that diabetes prevention and cure are the goals for them. So when patients with diabetes visits our clinic for consults, our goal should be to cure that diabetes. The goal is to help patients understand the necessary elements to accomplish diabetes cure by providing them education and skills to accomplish such goal if it's at all possible. So I hope that from now on, whenever we hear our colleagues telling us or telling our patients that diabetes is incurable, that it is a disease for life, this is the chance, a chance for us to share and for us to educate them as well, that it has been defined long time ago. It's just that it's not translated to clinical care for patients with diabetes. Now, I'd like to introduce Lifestyle Medicine Resource. This is the country's first and only lifestyle medicine interface that integrates lifestyle data analytics. So, we are partnered here with the Health Snap from the United States, and we have here lifestyle programs as well that are delivered online and remotely, including monitoring. And this also works with telehealth system. Of course, we integrated group support, and we embedded lifestyle medicine learning resources, both for the practitioners, for physicians, for allied health practitioners like nutritionists and dietitians, and lifestyle medicine coaches. This is one interface that the Philippine College of Lifestyle Medicine is working at, and so that we can somehow deliver quality and sufficient lifestyle medicine care to patients even remotely. And the interface will be officially launched in the month of December after the lifestyle medicine certification exam. So please look forward to it, and we will be posting updates about it. Now, lastly, we know that it is estimated that patients diagnosed with type 2 diabetes have an average reduction of life expectancy by up to 10 years. And this depends on their age, the treatment they had, and of course, their lifestyle factors. Our goal here as lifestyle medicine physicians and lifestyle medicine advocates is to motivate our patients and to let them understand that they have to take their life back. They don't have to let diabetes waste a decade of their life. If you're interested to learn more about pre-diabetes and diabetes type 2 remission and reversal program, you may want to visit our website and see the details for the training. So thank you so much for joining us this afternoon, and have a great day.